Good afternoon everyone. So today we are going to understand about febrile neutropenia. What are the interventions and how do we manage a patient of febrile neutropenia? So if we talk about febrile neutropenia, if we talk about oncology, febrile neutropenia is a medical emergency. That means we should treat the patient the same way as we treat a patient of a stroke or MI. So febrile neutropenia is a medical emergency. It is seen on the patients who are on chemotherapy. It is very important to train our nurses and supporting staff in how to manage febrile neutropenia, and the reason being early assessment is very important, and it is more commonly seen in the hematological malignancies as compared to the solid tumors. So now why it is important? It is important because a patient who is undergoing chemotherapy for a particular oncological problem, he might this whole episode of febrile neutropenia might compromise the clinical outcome. It increases the mortality, which is different from the mortality due to disease itself. It prolongs hospital stay, and in that way it also causes more financial burden on the patient and the family. It increases diagnostic as well as treatment cost. It also not only increases financial burden, rather it also delays the actual chemotherapeutic regime. So whenever a patient undergoes is admitted with febrile neutropenia, we might have to delay the chemotherapeutic cycle. And also sometimes if a patient develops severe toxicity, we might have to even reduce the chemotherapeutic doses, which might alter the outcome or change the protocol. So how do we define febrile neutropenia? So fever means any single oral temperature of more than 101 degree Fahrenheit or a temperature of more than 100.4 which is sustained for more than an hour. So either of these condition is referred to fever. And what do you mean by neutropenia? Neutropenia means ANC. ANC means absolute neutrophil count. So ANC below 500 per millimeter cube, or ANC that is expected to decrease below 500 during the next 48 hours. So if any patient who has taken a chemotherapy cycle and we expect that the neutrophil count is going to fall, which is usually by days 8 or 9, so we expect that the ANC is going to fall. So in that situation also we consider it to be neutropenia. And how do we calculate absolute neutrophil count? We calculate it by measuring by adding the mature granulocytes plus neutrophil or band cells or stab cells. They constitute neutrophil count. So how do we do that actually? So we have a whole blood white blood cell count in our CBC. We multiplied it with the percentage of neutrophils. Now if you see this report, can you see this? This is a report of a patient with febrile neutropenia. So there are three things which I have marked. One thing is a WBC count, which is 1500. So the normal is 4000 to 10,000 per millimeter cube. This is 1500. And if you see, the hemoglobin is 10.8, and this thing, another thing which is marked is 23. 23 is 23%, which is low. So there is the patient is neutropenic. So in this case, how do we calculate the value of ANC or absolute neutrophil count? So 1500 into 23. That is 345. So as you see, the counts are below 500. So this is a febrile neutropenia. We also have grading of neutropenia, in which we divide them into mild, which is 1000 to 1500, moderate is 500 to 1000, severe is less than 500, and profound neutropenia where ANC is less than 100. So if you see why it is an emergency, it is an emergency because immune system is impaired ability to mount inflammatory responses. So such patients who are on chemotherapy, who are already immunocompromised, their immune system has decreased ability to combat the microbial organism. Bacteria are the most commonly responsible organisms for febrile neutropenia, and these organisms can lead to complicated infections, to infections which are at unusual sites, sometimes infection with even unusual organisms. So that is why it is an emergency situation to deal with febrile neutropenia. In 50% cases, while we send a blood culture, we do not find any infection. 30% only are microbiologically documented, and 20% of the infection are also clinically documented. So out of these, bacteria are 70 to 90%, fungi are there in 15 to 5 to 20%, viruses 2 to 5%, and parasites are less than 1%. So it is very important while managing the patient of febrile neutropenia that you assess the risk. Why is risk assessment important? Because the type of empirical antibiotic therapy, so whether you will use an oral antibiotic if a patient is not having a severe neutropenia, or if we know that the patient is about to gain his counts, we might as well give oral empirical antibiotics rather than giving intravenous. But if you suspect the patient is going to be neutropenic further, then it is very important to admit the patient and administer IV antibiotic. The venue of treatment, again it is very important to decide whether you want to treat the patient on OPD basis. Again, a patient who is not having very severe neutropenia, you can treat on OPD basis, while the patient who are having severe or profound neutropenia need to be admitted. Duration of antibiotic therapy also depends on the duration of neutropenia as well as the organism detected. So who are the high risk patients? So the patients who have recent intensive chemotherapy, as we know that their counts are going to fall by day 8 or 9, then those who are having profound neutropenia, that is the ANC is less than 100 and or anticipated to extend to more than 7 days. Any focus of infection like cellulitis, abscess or pneumonia or diarrhea, if there is any evidence of hypotension, so this is a very important marker. You have to measure the blood pressure of any febrile neutropenic patient and see if he is in hypotension, he or she is in hypotension. You must immediately upgrade the antibiotics and suspect a gram-negative sepsis. So another thing is if the patient is in respiratory distress or the patient is hypoxemic. Mucositis, because mucositis might impair the ability to for oral intake or resulting in diarrhea. Again, you have to be very cautious. Low risk patients are those who are clinically stable, who have no medical comorbid conditions, and neutropenia is anticipated to last less than 7 days. It can be managed on OPD basis with follow-up. So there is a important score also, masked febrile neutropenia risk index, which have various characteristics which are given various scoring, and this is how we determine whether the patient is at low risk or high risk of complications. So how do you assess the patient? You need to take a detailed history, because you need to determine what phase of treatment the patient is on, the recent chemotherapy received, and disease status, whether the patient is in remission or not. So a patient who is not in remission will have a more severe course of febrile neutropenia. Anticipated degree and duration of neutropenia, as I already said. History of recent or prolonged admission to ICU. So that will tell us that the patient is might able to contract some pathogens which are hospital acquired also. Resistant patterns, so we need to know the resistant patterns in our hospital, and accordingly we should treat according to the antibiotic. History of fungal infections. So we do imaging, we do culture review and find out whether there are any fungal infections or not. So the first and foremost thing are the vitals. So vitals are very vital. It is important to note the heart rate, blood pressure, respiratory rate and BP with appropriate cuff. So you must remember, for small children we should use the age appropriate smaller cuff and not the bigger cuff as adults. Oxygen saturation, so these three are very important. These four things need to be measured in the emergency itself. Then systemic examination, GI you look for any tenderness, abdominal tenderness, ascites, peritonitis. In respiratory you look for signs of tachypnea, distress, and you need to auscultate. In CVS look for murmurs, and CNS look for meningitis and any focal neurological deficit. Examine the patient as a whole for skin orifices, especially mucous membranes, and the areas which should not be missed are intertriginous areas, oral cavity, perianal region. And the one more important thing in our oncology setting, you need to examine the central line site, because that is a very important site of infection. You need to look at the now what initial investigations we order. So we ordered CBC, LFT, RFT, and it lies the most important investigation is the blood culture. So after this you need to blood culture should be the first specimen and should be taken prior to antibiotics. These are the common microbes which are seen, and with the management you have to give IV fluids. If hypotension, immediately give first dose of antibiotics. So first dose of antibiotics should be given within 1 hour of reaching the hospital. Give oxygen support if the patient is in respiratory distress or hypoxia. If the patient is stable, you can give oral antibiotics and discharge the patient. If unstable, you might need to upgrade the antibiotics also. So for central line associated bloodstream infections, you have to be very cautious, examine it properly. And you need to monitor the patient on a daily basis. If the patient improves, you might discharge the patient and stop and taper down the antibiotics. So the nurses need to know all the signs of sepsis so that they can identify them early. Important nursing interventions: prevent infections and complications, prompt recognition of warning signs, adequate monitoring and charting, and administering the antibiotics in the golden hour. And we need to educate the family even prior to this episode of febrile neutropenia. Febrile neutropenia is an oncologic emergency. It is most important determining factor for IV antibiotics, and nursing staff should monitor the patient and report for any concerns to the doctor or treating team. Best outcomes are achieved by interprofessional team approach. Thank you.